Hello, GAP MASLD MASH Community Network. My name is Lindsay Yoder. I am a PA in Hepatology at Indiana University in Indianapolis, Indiana, and I wanted to take a couple minutes to go through a couple of common questions that I get from our general GI colleagues. One surrounds the actual diagnosis of MASLD and MASH. So oftentimes when patients have liver enzyme elevation and you're doing that serologic workup to rule out other causes of liver disease besides MASLD MASH, there are some patients that will have a positive autoantibody, ANA or ASMA, maybe a little bit of a ferritin elevation, just something that's not quite negative or normal the way you want it to be and would be easy to rule out everything else. What I can share with you is that we have published data where up to 30% of patients with MASLD or MASH have a reactive or positive autoantibodies that are not clinically relevant and not concerning for autoimmune hepatitis. So make sure you put all of that serologic workup into the greater context of all of the non-invasive data that you have for the patient. And if you have someone who really has an elevated IgG, ALT elevation, fatigue, pruritus, and it makes sense that this person may truly have, an overlap of autoimmune hepatitis with concomitant MASLD or MASH. These are the patients sometimes where we're still leaning on liver histology via a liver biopsy to make sure we're not missing anything else. But again, my recommendation is just to really wait until you have all the serologic results back and put that into context of the person, sitting in front of you or that you saw in clinic. If their ALT is 19 and their ANA is positive, they don't have any history of personal or family history of autoimmune disease, their IgG is normal, then that reactive ANA alone shouldn't be enough to cause concern for a true, autoimmune hepatitis concomitant issue. Another common question I get from our community GI partners is, when should I refer my patient? So being at Indiana University, where we are a tertiary liver care transplant center, my recommendation is that, we're happy to take anyone you want to refer to see us. That doesn't mean we might not eventually, after a couple years of following someone with a normal liver stiffness measurement and no hepatic fibrosis, return them back to primary care, endocrinology, or cardiology monitoring. But those patients who are starting down that road of moderate to advanced fibrosis, F2 to F3, certainly the patients with F4 cirrhosis, these are appropriate patients to refer for hepatology care, academic care, transplant center care. And then another common question I get is that differentiation between MASLD, MetALD, and ALD. Assuming there's nothing else going on like medications or other concomitant liver diseases that make you think about other steatotic liver disease etiology, if it just comes down to someone having metabolic syndrome factors and alcohol use. If they drink more than 4 drinks a day, they have alcohol-associated liver disease. Doesn't mean they can't also have features of cardiometabolic, risk factors, but if they're drinking more than 4 drinks per day on average, that means alcohol is playing the greatest role and it's the greatest risk to them in their liver health. If you have someone with metabolic syndrome, and for women, they drink only 1 drink or less per day, and men 2 drinks per day or less, you can confidently call that MASLD. And then if someone is not quite drinking 4 drinks or more a day, so if they're drinking 2 to 3 drinks, let's say for women, that's MetALD. And if it's somewhere between 3 and 4 drinks a day for men, that's MetALD, where you have to recognize that there's enough alcohol use that's probably contributing somewhat to their steatosis, but they again also have those cardiometabolic risk factors playing a role as well. Thanks for tuning in, letting us discuss some common community GI questions about MASLD and MASH.